we can understand the brain as a network of electrical signaling stations. There are 100 billion or so of these little signaling stations, and our job in part is to decipher the electrical codes that these neurons are generating in order to understand what a rat or a person is currently feeling, thinking, experiencing, perceiving, that sort of thing. And we've been making substantial progress on these fronts. There's a very serious unmet need for being able to record brain activity in the emergency department. And brain activity is typically not recorded in an emergency department for several factors. One is it's technically difficult to record EEG in the emergency department due to all the equipment that's around generating noise that looks very much like brain signals. Well, we've solved that problem because we're capable of recording brains of rats who don't treat our electronics very gently. That's cheap and lightweight. And I'm going to ask my colleagues, Dr. Sama Abdelbaki, I'm going to call him Sama from now on, and our patient, Dr. Omortag, I'm going to call him Ahmet. Ahmet is going to simulate a patient in the emergency department who has come in an altered mental state. In the kit that he has, everything required for recording an EEG is in this envelope. Imagine it's a sterile envelope. Physician or technician comes, opens up the envelope, and if you started a clock, you'd see it'll take about 3 or 4 minutes before we're actually looking at the activity in Dr. Mortag's head. The importance here is that the electronics has solved the problem of screening out the noise from this video camera, from your cell phones that are sending signals, all the electricity that's running in this room. And we've demonstrated in patients at University Hospital, rather at volunteers at University Hospital, that we can record EEGs while they're hooked up to pulse oximeters, EKG machines, oxygen delivery systems, IVs, without artifacts. In fact, we can record as well as we can record in the neurology department. So what's happening now is a cap with electrodes is being placed on Sama's head. The electrical activity of that 100 billion neurons is able to permeate through his scalp and produce very small signals. Ahmed's head is not unique in this way. All of our heads. Yeah. So what Sama is now doing is not injecting anything. He's just he's just delivering an electrode jelly that increases the conductance between the electrode and the scalp. It's just basically salt water in jelly. So while he's doing that, I'll draw your attention to the system that we've developed. We describe it as emergency EEG. And the key here is everything necessary is in this kit. It's semi-disposable, so it doesn't cost tens of thousands of dollars anymore. Per use, we imagine this is on the order of tens of dollars. The electronics is the key here. It's short, it's small, it's cheap, it's easy to refurbish. And what will happen in a moment is Sama will attach the electronics to the cable on this cap. He will go to that medical PC there, enter some patient information and say begin. The electronics will test whether he has activated he has connected the electrodes appropriately. If he's done it inappropriate, it will tell him to correct it, and it will start recording his EEG. There's a big problem in implementing this, and that is there are no neurologists in the emergency department to read the EEG as it comes in. And the way we've solved that is by this wireless transmission. The device is picking up the signals, wirelessly transmitting it to that slate over there, and from that slate it will, when the recordings are done, it will use the internet to send it to a server where a remote neurologist, due to regulatory concerns, that remote neurologist is probably in a different department in the hospital, but it could be someone else, a neurologist at another location in the city, and eventually, regulatory environment allowing, it could be a neurologist who is effective but cheap at some neurology bank, for example, in Bangalore. This is the internet, and it wouldn't make any difference. In the emergency department, where there are several people working on this patient, there are no cables to trip over. There's no danger of electrocuting the subject because there are no wires connected to the wall. It's all run on cell phone technology, basically.
So this is mobile, so could you actually like have this on an ambulance or something?
Yeah, in fact, this was developed
to?
for under NIH funding. The specification was it was for Homeland Security. There was a concern that there could be a nerve gas attack at a subway, for example, and if there was a nerve gas attack, people can have seizures but be paralyzed. So the first responders wouldn't know to treat the seizures, and you want to treat a seizing brain. So this was designed so that we could record in a subway, on the street, in the back room at a restaurant. And it was designed so that it could be taken into an ambulance, and it would follow the patient, so that in the event of a nerve gas attack, many hospitals don't have hundreds of these things, but we can provide hundreds of these bags, and the signals are being recorded, they're being transmitted. You need one PC to see whatever's there.
Okay. I think that's good also, but sometimes also in terms of trying to get the patient to the appropriate facility that can best take care of them also, because that's what would happen more often.
Indeed.
You know, so like if we have a comprehensive stroke center at Downstate and maybe another hospital does, normally they will try to get to the nearest hospital, but they have the capability of knowing maybe we ought to go right to a Downstate. You save valuable time, especially if you're trying to do something within like 60 minutes or 90 minutes, as we sometimes have to do.
You're a hospital administrator, so you know that in order to get this test done, it might take many hours, even days. And in time, you're doing other tests that are expensive and unnecessary. Okay? So if you bring a patient into the emergency department, do this immediately, you might appropriately triage them. And while that's great for patient care, it's also good for hospital operating costs.
Thank you.
In terms of sensitivity and specificity, is it exactly the same as the larger?
Yes, it's actually better. It's actually better. The reason it's easy to explain why it's better is because the signal fidelity is actually better. That's not a big surprise. Remember, I've been recording harder signals in rats' brains while rats are jumping and beating their heads against the wall, and we've been doing that for decades. And this is essentially taking that technology and saying maybe it's useful for something other than teaching us about the basic science of the brain, and we're using it now in the clinic. Or we're attempting to start a serious clinical trial actually at University Hospital and Kings County to hopefully NIH will smile upon us and give us the money to pay for the patient costs. But we'd like to do a clinical trial and actually measure the impact on patient outcomes and on hospital operating costs should this be added to the protocols of the emergency department.
Does it have any usefulness for ambulatory EEGs?
It does. In fact, I'll say it this way. Our intention is to take this core technology, this core basic way of recording from the brain in an efficient and cheap manner, and have brain recordings everywhere. So our fantasy would be to use this for seizure detection. Let's imagine you have epilepsy. Most people that have epilepsy, the trouble is you don't know when you're going to have a seizure. Okay? The seizures can be managed in one way or another. You often have seizures that only happen once or twice a year, okay? But you don't know when. And that limits what you can do. It limits whether you can drive. It limits the jobs that you can have. Our fantasy is that we miniaturize this and we have this efficient way of recording from the brain. Smart people like Dr. Martag, when he's conscious, are working on algorithms, yes, you can open your eyes, are working on algorithms to detect, to do that mind reading, if you will, from these signals, to identify that a seizure is imminent or you're in danger of having a seizure and give you a warning signal. And that would require this ambulatory. Closer to that are people who typically go to the hospital now with epilepsy for treatment, they are interned, if you will, in the hospital for up to a week to 10 days waiting to have a seizure. And that's non-ideal because the neurologists remove their medication or trying to provoke seizures. The ideal thing would be to give them one of these and let them go home. It would be a lot cheaper. You wouldn't be paying these enormous costs for the patient to sit in a hospital bed waiting to have a seizure. They can sit at home and wait to have a seizure, making this much cheaper and more effective.
Will it eventually, or maybe it does now, have something to do in indicating different types of mental illness?
So you've anticipated my research program. If what I called mind reading, the goal there is to try to find brain signals that correlate what I told you about with schizophrenia, but we're also working on depression, panic disorder. You can imagine from a basic science point of view, everything that you do, okay, comes as a manifestation of your brain activity. Okay? And if we can decode that brain activity to say, it is now in a regime that is abnormal for you and you have a debilitating abnormality, you could use this approach, one of deciphering, doing this mind reading thing, deciphering those neural codes and being able to record them in a effective manner to revolutionize how you would treat mental dysfunction. Right now, the pharmaceutical model is to give you a pill, okay, right, that goes everywhere and acts all the time in your brain. Okay? Ideally, what you want is something that acts when you need it, where you need it. Okay? But you don't know when you need something. That's right. You need something like a neural thermometer. That would be the analogy that we use in our company. And this kind of effort is moving towards building such a thing. And you would use this to identify abnormality in brain state. We're making progress also in Fragile X mental retardation and autism. There are signals that I can see in mice that have the abnormalities underlying Fragile X mental retardation that we can pick up from electrodes very similar to this in mice. And again, you can imagine that being used ultimately to chart the course of treatment for a child who unfortunately has some form of mental retardation, but you're making some kind of interventional therapy, and you no longer have to rely on the behavioral scores. You can actually ask, what is the brain doing directly, and treat that. That would be the ultimate goal. I don't see that we're going to do that in 5 or 10 years, but that's the ultimate goal of this kind of effort.
André and his colleagues have just provided an exquisite explanation for why academic medical centers exist and why they're different than hospitals. There are 125 institutions in the United States like this, where a person, obviously with a lot of talent, people with lots of talent, can go from the most basic kind of research, submolecular research, to an application that has not only clinical applicability, but also commercial applicability. One of the reasons we're trying to build a biotechnology industry in Brooklyn is to take advantage of these kinds of translational discoveries that go from the most basic sciences. Every time I see some congressman get up and talk about waste because somebody has done some piece of research that doesn't seem relevant to anything, it curdles my blood, because it's that kind of work that leads to this kind of product. And I think what Andre's just demonstrated is how the most fundamental kind of electrical signaling leads to a product that has obviously great not only clinical application, but probably commercial application or commercial success. It's a major step forward, and not only that, but it leads into all kinds. Many of you just said, "Gee, why don't you do this? Why don't you do that?" Because it leads into all sorts of things that you never expected it to go. That's what science is all about. There is no other institution in Brooklyn doing anything remotely like this. And so when we say this is the only academic medical center from the edge of Staten Island to Stony Brook, east of the East River, that's what we're talking about. And to some extent we can get lost in the weeds, you know, all the problems with patient care and hospitals and all of the things that are very, very important, but we can't lose sight of the fact that this is what makes downstate a distinct institution. There are plenty of good, wonderful institutions in New York City, thank goodness, and in New York State and in the United States. But 125 isn't a lot. So when somebody tells you the NIH budget is too big, it can't be too big. This is the way the future happens. This is the way the United States stays ahead of the game. And it's foolishness to be thinking that a few $1 billion out of a budget, which, you know, they're talking hundreds of billions, shouldn't go into the kind of work that produces these products. And that's, I mean, you know, I struggle to find ways to convince people of this, but all you have to do is see one example, and it's there. This is repeated I don't mean in any way to trivialize this work, but this kind of pathway is repeated every day all over the world, but mostly in the United States, because the United States, since the end of the Second World War, has made a commitment to doing the sort of basic research that André and his colleagues, as you've heard, also do, that leads to these very practical things. Now, I don't think there's any way that I could say that more eloquently than just listening to this process. That's why we're here.
Excellent presentation.
Very, very.
We wish you luck.
Yeah.